Hello, everyone, and welcome to Successful Feeding Therapy and Coffee with Rachel. I am Caroline Thorpe, and I'm pleased to have you all with us in this important session. We are delighted to welcome Rachel Rose back to the PURA conference this year. Many of you will remember Rachel's extraordinary presentation from last year, Getting into Your Child's World, Speech and Language Therapy. Since that year conference, Rachel has become much more involved with our community. Now, I just wanted to add a personal bit of information here. Rachel, after the conference, I contacted her and she started working with my son, Joshi. This is obviously from a long distance. She's in New York, we're in Spain. And she has managed having that distance more with Joshi than any other therapist has. I can't express, there are no words for me to find to express the gratitude I have towards her, simply for helping him see his therapy in another way and learning things that we couldn't think were even possible. We're about to begin this session now. If you would like to ask a question, please use the question box located at the bottom of your screen. And following Rachel's formal presentation, we'll have time for questions and to continue the discussion with Rachel. So please have your thoughts and questions ready. At this time, I would like to formally introduce Rachel Rose. Rachel Rose is the founder and owner of Creative Speech Therapy NYC. She is nationally certified through the American Speech and Hearing Association and state licensed in New York. She also holds the Certificate of Teacher of Students with Speech and Language Disabilities. Rachel earned her bachelor's degree in Hearing and Speech Science from the University of Maryland and her master's degree in Speech Language Pathology from Loyola University. She worked for over 10 years in public schools, early intervention, child find, and sensory gyms. She expanded her work into the private sector in 2016. Over the last 7 years, she has earned 3 awards for postgraduate education work in the areas of pediatric feeding and speech language, with specialized training in orofacial myology, prompt, SOS, Talk Tools Level 2, and TOTS. Throughout her career, Rachel has focused on working with children with multiple disabilities and significant needs. Rachel speaks publicly about pediatric feeding, oral placement therapy, speech language development, and social skills. She is a creative therapist who focuses on tailoring individual therapeutic programs for each child based on her knowledge of traditional and innovative techniques. She strongly encourages collaboration with parents, teachers, and other therapists. We are so excited to have her here, and please help me join and welcome Rachel Rose.
Thank you so much. You made me start with a little cry session there, and then thankfully it was a long
thank you
of my credentials there to get me back on track. I'm thrilled to be here. I'm thrilled to be working with Caroline on this talk. As you mentioned, I worked with Joshi for a while, and so it's just nice to have a familiar mom face to do this with. So I'm going to go ahead and share my screen. And so yeah, last year I talked about language therapy, and today I'm going to talk about feeding therapy. And actually, a lot of this was just said, so I don't need to go through much of this. I have 3 children on my caseload who have a diagnosis of PURA, so I have a little bit more experience than the average speech therapist. And like Caroline said, I've taken a number of courses in the area of feeding postgraduate because that has really become kind of a passion of mine. Although I still work with articulation, language, all kinds of other disorders that are related to speech. But that's kind of where my specialty is. So I love talking about feeding. Before I continue, if you have a snack and a drink, get them ready because we're going to do a little experiment in a few minutes. So kind of get that ready so we can do that together. Okay, so the first thing I wanted to mention is kind of what does feeding include? And while there are many things that feeding includes, they're really, to me, thinking through this to present to you, there are 3 main categories. The first is that feeding is very social. The first relationship that a child has when they're nursing with their mom is that time of eating. It forms a bond, it's a connection. Even when dad is holding the bottle, these are social times. Kids will often smile, they'll kind of try to make a sign to show the mom what they want. And it continues throughout. If you think about holidays, going to restaurants, like these are all very social events. What I often find when you have a really picky eater is that it ends up being kind of the child sits and eats their particular meal on their own, and they're not necessarily eating with families. And they don't have a lot of experience or opportunity to socialize during that time. We're going to talk more about that later. But the second part, and we're going to talk a lot about that in a minute here, is that it's muscular. So when you think about all the things that have to happen in order for you to chew food, you have to really coordinate all your muscles. You have to have the right amount of strength in your muscles. All of that has to coordinate and go into effect in order to chew and swallow. And then the third piece is sensory. So if you think about, all the sensory pieces relating to eating, there's sight, smell, sound. Really crunchy foods are really loud in your head. And then of course there's taste. All of those sensory components go into feeding, and they also can change depending on the day or depending on the meal. So think about it as social, also muscular, and then also sensory. So speaking of muscles, these are all the muscles that we use to chew. So we have our lip muscles and our jaw muscles and our cheek muscles, and all of those have to work in concert. Oh, and of course, the tongue, that's the big one. All of those have to work in concert in order to masticate or chew food in order to properly swallow it. So for example, think if you have like a lip tie, so where your lip is kind of tethered to the top of your mouth, you probably aren't going to be able to effectively round your lips around a straw in order to drink from the straw. So that's going to be an issue. If you have a weak jaw, then you're going to have trouble coordinating and moving your jaw up and down in order to use a mature chew pattern to chew things like meats and raw vegetables, which is why a lot of kids prefer not to eat those foods. All right, so let's do a little experiment. If you have a liquid in front of you, doesn't matter what form it is. I have straw, cup, and another one here. But just take a sip and kind of think through all the things that's happening in your mouth as you're drinking that liquid. So if it's a straw, you're rounding your lips, you're sucking in. What is your tongue doing to get that liquid to the back of your mouth? If you're drinking from a cup, where do you have to place it in order to get it, in the right spot? Typically, you place the cup at the bottom of your lip, then you tilt your head back slightly, your top lip comes down to meet the cup, then your lips have to close really quickly to capture that liquid, and then the tongue has to move up to the palate and then get that liquid all the way back in a wave-like motion to the throat. So all of that has to come into play when you just drink out of a cup. Food is even more complicated. So if you have a snack, take a bite, and while you're eating, think about these things. What part of your tongue touched the food first? Where did you move it? How did you get it there? What part of your mouth got the food to where you put it? How are you keeping it in place as you chew? And where did you put the food in order to swallow? So here again, typically the tip of the tongue touches the food, and then that tongue moves it to your molars, or where your teeth are. Even if the kids don't have teeth, it's on that gum line. They get it there by moving their tongue. So it's called lateralization. You're moving the tongue side to side. And then you keep it in place by holding your tongue on one side and your cheek on the other. And that's how you keep the food on your teeth. And then you move it to the back and center of your tongue for a swallow. So that's how a typical chew works. I work with a lot of kids who use compensatory strategies to try to chew food. So think about if you were to take that same bite of food, but you only chew it with your front teeth. And I work with kids who try to use this strategy. It's ineffective, but it can kind of work. If you're chewing it with the front of the teeth, your lips are going to pucker really hard to keep that food in place. Some of it's definitely going to fall out of the front of your mouth. Your jaw really can't move up and down the way it's supposed to. You're probably going to smash that food into the roof of your mouth, or what's called the palate. And when you try to swallow it that way, you usually gag. And that's going to cause some children to have even a food aversion because they think if I get this in my mouth, I can't swallow it. So I just wanted to kind of get you guys familiar with how complicated it is to eat. We take these things for granted, right? We know how to drink from a straw and all of that stuff, but really so much goes into it. And so you'll see later how I break down some of these skills in order to teach the gestalt, the drinking out of a straw, eating off of a spoon. Another way I like to describe the mouth is sort of like a house. So if you think about the floor of the house, the foundation of the house is like the jaw. So if your jaw is not steady and stable, then you don't have it. You have a shaky house, right? The walls aren't going to hold up. The roof's probably going to cave in. So the jaw is so important to work on. If your child is struggling with feeding, you really want to think critically about their jaw and think, is their jaw strong enough? You want to consult a feeding therapist, but just think through, is their jaw strong enough to kind of hold these foods in place? The lips are the front door. We talked about if your lips don't close or if you're chewing in a different way, food's going to fall out the front door. The cheeks are the walls. They're holding that food in place. And then the roof of your mouth is your hard and soft palate. So that's that part of your mouth that is the space between your nasal cavity and your oral cavity in your mouth. And then the tongue is sort of the people inside moving all the things around. So if you think about also like a tethered oral tissue or a tongue tie, if that tongue is tethered to the floor of your mouth, it's going to be really hard for you to trap the water and move it back using that wave-like motion. And it's going to be really hard for you to move your tongue side to side to move the food where it needs to be chewed. And so those kids are also going to have compensatory strategies. Okay, so why is chewing important? Now that we know kind of what's involved with chewing and how we do it and how complicated it is, chewing is really important. Number one, well, for many reasons, but the first one I put was for attention and concentration. And I always like to kind of use the example, think about like today, you're attending a long conference, there's a lot of meetings, you're trying to like pay attention. But what do people do when they're trying to pay attention? The number one thing is they chew on something. So they might chew their pen caps, they might chew fingernails, they might chew gum or have candy like gummies and things like that. Those are all things that you're doing in order to keep your attention up. That's a lot of the reason why they serve snacks and drinks and stuff at like a big conference. So attention and concentration is great. And that's a skill that your child can be building from beginning of life, is to really help them focus and attend. Believe it or not, chewing helps shape the face. For those of you who attended last year, you'll remember Jack. Jack is also featured in this talk. You'll notice that in the beginning, when I meet Jack, he has these really cute puffy cheeks, which are great, except that it's showing me that he's not using his cheeks to eat. It shows me that he's not really an oral eater. And so you'll see as we start to teach Jack to eat that those cheeks start to go down and down and down into like a little toddler face. And then it's also important because it starts the digestive process. So when you put food in your mouth, saliva begins to form, and then things inside of your body are happening. So if you're fed with like a G tube, then a lot of that stuff isn't really happening. You're not getting that attention and concentration. You're not shaping the face. That body isn't starting that digestive process, which is why we want to get kids from a tube to an oral feeder as soon as possible and when possible. And kids typically learn to chew foods in a specific order. It's usually liquids, purees, soft solids, and hard solids. So they're kind of in order of easy to difficult, and then they're developmentally based on how the baby grows, the reflexes they have, how they start to gain control over their body, all of those things. So for most kids, we work this level. For some kids, we don't work in this order, and it could be for many reasons. So maybe they may not be able to safely swallow liquids, but they may be able to swallow a puree because a liquid goes down fast, but a puree goes down a little slower. So if they're having difficulty coordinating in their body, like a suck, swallow, breathe pattern, then we need to slow down the transit time for the food. And that's just one way to do it, as an example. And I always have to include this in any talk I do about feeding because it's so important to me and to feeding therapists and for you. It's positioning your child in the chair. I often go to a first feeding session and I see kids in these chairs and they're leaning and they're dangling, and the parents saying like they just hate getting in the chair, they don't like it. And I say, well, sure, because they're not in a proper chair. I sort of liken it to when I'm kind of short, and when I sit on a bar stool, the chair is often very small and my feet are dangling. And so I'm constantly moving around on the stool, trying to find foot support. I'm tightening my muscles, different muscles to kind of compensate. I'm tightening my legs. It's just hard for me to sit upright. And so I get squirmy. Same with children. If they're not in a proper position, you're not going to get the best coordination of the other muscles. So this is also like a PT thing that they really emphasize. So the first is to make sure your child is in neutral flexion. So think about the word flexing is muscles and neutral is like not doing it. So sorry, one sec. So you want to have the child sitting in a position where they're, again, not having to use other muscles to help keep them in place. How do you do that? You make sure that their feet have an adequate foot support. If you look at this high chair here, there is a footrest that moves up and down depending on your child's growth and where they fall. And you also want to make sure that they're in a 90, 90, 90 degree angle. So if you think about just like the classic stock photo of like that line drawing of someone sitting in a chair, it's like their back is against the seat, their legs are bent, their hips are bent, and their feet are on the floor. That's what you're looking for. So if you don't have the right chair, don't fret. You can use things in what you currently have in order to adjust the chair. So sometimes I'll shove some like burping cloths or pillows or blankets in just to make sure that everything is in the nice and upright position. Okay, so we're gonna go through different ways that we eat and how a feeding therapy session should look or could work. So in this part, I want you to start thinking about your own child. Think about where they fall on this continuum. And I also want you to notice there are many, many steps to teaching a child to drink. Obviously, we can use cup, open cup, or straw. In this talk, I decided to just pick straw drinking for the sake of the example of it. And we'll go through that right now. All right, so those of you who took my talk last year would remember Jack. Jack is a child who has PURA. He lives in New York. I've worked with Jack since he was a baby, and I taught him to eat and drink. Mom gave me permission to share any videos of Jack as long as he's having a good hair day. So Mom, if you're watching, I promise these are all good hair day videos. The first video you're going to see is early on when I first met Jack, and he was really exclusively drinking from a bottle and he wasn't doing a great job. So we're trying to transition him over to a straw, and it goes pretty well. Notice he has the really big chipmunk cheeks, right? So that's an indicator that he's not using his cheeks to eat and suck. He's probably using compensatory strategies. So at this first level, Jack didn't even know to open his mouth in anticipation of a straw. So I used a tapping method to tap his lips to sort of wake them up. And you'll see him learn, oh, okay, when she taps, I open my lips naturally, and then the straw goes in. So now I know, oh, when I open my lips, then I get this straw. You should know that Jack is very motivated by food and drink. He always has been. His first sort of like steps were towards a glass of water. So Jack loves food. In this video, I'm also using a honey bear that I preloaded the straw. So I've squeezed the honey bear, so there's a little bit of liquid in the straw. So basically all Jack has to do is open his mouth and I squeeze it in. All right, so let's see. Big, good hair, but big cheeks on Jack.
Tap, tap, tap. Tap, tap, tap. A tap, tap, tap. Good job, buddy. Good job. That was a long one I gave you. Good job. You're making progress, even in one session. Let's swallow. Good swallow.
That was a good swallow.
Tap, tap, tap. Good. Whoops. Good. I'm just providing a little support to the chin at the end there. There we go. A tap, tap, tap. Good job. Close. Good.
All right, so that's Jack starting to learn how to drink from a straw. I'm not requiring him to do very much. He just has to open his mouth, and then I even provide a little support to the chin at the end so that he starts to learn to close his mouth. So I basically just push that chin up. You're going to see me doing that in the next video. In the next video, Jack is aware of the straw. He knows to open his mouth for it, but he doesn't yet know what to do with it. And a lot of parents, this is where I get called in because they're like, he's opening, but he's not drinking. So he's not rounding his lips. He's not closing his jaw to trap the liquid. If I squirt it in, it's just going to come all the way out unless I provide support. So remember, I'm just showing you snippets along the way. We had done things up to this point, and we're going to be doing other things after, but I just wanted you to see that it's a long process. You have to sort of diagnose along the way, figure out what he is or is not doing, and then what you need to do in order to help.
Hold his chin, push, squeeze out. Hold his chin. So I'm pushing his chin up so that he can't bite the straw, but so that he learns a little bit more about mouth closure. I'm squeezing and I close. Let's get you back into position.
There's that positioning part. It's so important.
Squeeze, close. Squeeze, close. Squeeze, close.
So I should mention, a lot of children with PURA have low tone. And so low tone kids tend to like to slide and use something to help them stabilize. And so we added like a really thick insert into Jack's high chair to help him, again, stay in place, addressing the low tone issue. All right, wait till you see the cheeks on this guy now. We're still dealing with low tone, so I keep helping him stay in place, but he is doing the work now. He is sucking that liquid. So positioning here is key. I want to put that straw right in the front of his mouth. I don't want to put it too far back because I don't want him to bite it, and I don't want him to drink out of it like you would like a nipple. So where I position the straw is in the front and just in between the lips. You can hear it's a little noisy. That's showing me that he's not coordinating quite as much as I want him to, the suck, swallow, breathe, but it's better. And this milk is thickened with some rice cereal, if I remember correctly. And again, we're trying to increase the viscosity in order to slow the transit time. So because I know that Jack's a little noisy and he is having trouble coordinating, I'm going to slow down the process, because whenever you slow things down, your coordination improves.
Jack's ready. Ready?
Look at the cheeks.
All right, so you want to make sure that the straw is pretty short, and then when you put it in his mouth, you want to make sure it's in the front like we talked about, and then just hold it right at the tip, and then you'll feel if he is biting, and you want to make sure he's not. Like there, he got a grip on it. So you pull it out, push it back in, go back. Try to keep head up. Try to keep strong.
So I keep trying to reposition, and then I figure this move out, and that seems to help.
Whoa, he wants it back in. Can you move your hands?
There you go. So yeah, I mean, again, it's all very diagnostic along the way. You could see I kept kind of putting Jack's head, you know, in the right position. It wasn't working. So we had to figure out a solution. We had to figure out a hold that would help Jack stay in the right spot so that he could focus on what he needs to focus on, which is the actual drinking of the liquid. And then here's Jack drinking from his on his own from a straw cup. The straw is the first straw in the Talk Tools hierarchy of straw drinking. Some of you I know are very familiar with Talk Tools and have some of their tools. Pro tip here for those of you who are at this level: we tucked the cup into Jack's bib because he was not necessarily a neat drinker yet, but he was drinking. So the bib catches all the spill. And there you go, pro tip.
So that's really, really nice to see. Yeah.
Notice he's sitting in a nice position. He's in neutral flexion. His head is up. He is doing all the work himself. So that's how I taught Jack to drink from a straw. And today Jack drinks independently smoothies and water and all different kind of things with a handle cup, regular straw at this point, and he's very good at it now. Okay, so the next texture after a liquid is a puree, and those are things like applesauce, hummus. They're usually the first foods for babies because they're very easy to eat. During this part, I want you again to think about your own child, if you have a child with PURA, or if you just have a child, and think about how they eat their purees, because there's different methods of feeding them that might be helpful for one child versus another, and I'll show you both in a minute. When do we introduce pureed food? So I get asked this question a lot, and the answer is not necessarily at that 6-month period where, you know, the docs say, okay, there's 6 months. I like to look and make sure that there's a safe way to do it. So I want to make sure that they can hold their head up on their own, or at least like I did with Jack with support, that they can sit up in the chair on their own, or they can do it with some rolled up things and support, but they're able to just kind of be independently, head up, sitting in the chair. If I have a child who's leaning like this in the chair, I know that's not safe because that airway is going to be compromised when they eat. And then you also want them to start having interest in food. So the child should be leaning in to receive the spoon. If they're really not about it yet, then, you know, wait a little bit, get them a little interested in foods, maybe by playing with them or smelling them or things like that. And then here's a chart I just provided. It's just some ideas for if you're trying to increase like calcium versus versus protein versus the vitamins and minerals in fruit and vegetables. These are different ways to go if it's a puree. There we go. All right, this is Dylan. And now his mom granted me access to share her videos as long as I cut out the commentary because she was saying silly stuff to Dylan. He has a syndrome called Spritzen-Goldberg syndrome, and he has some malformations. And so we have to kind of think about that as we work on feeding him. You'll see later how I get him to eat solid foods, but he was really struggling with spoon feeding. So what I suggested was, I call the 90-10 method. So I suggested front spoon feeding for him. And I suggested, this is dad feeding. I said, go 90% of the way and let Dylan come the remaining 10% of the space. And that really was a game changer for Dylan, because then he's realizing I may not be able to hold the spoon or do all this stuff, but I can choose when I'm going to eat the food. And he started really coming in for the spoon at that point. We were able to increase his weight and kind of keep him off of a feeding tube as a result of getting more and more food into him. So this is front spoon feeding. You're placing the food on the tongue tip, and then the child is just moving it back with their tongue in a similar way that we swallow liquids. So it's a nice, easy transition. That's why we start with purees with most kids, is it's kind of, you're still doing the same, almost the same movement as if you're drinking from like a straw or an open cup. Got a smile for the camera, pretty cute. Mom's gonna come in and help him reposition, because we talked about how position is key. And then, oh, he found an opening. He went in. Dylan likes it. He's gonna give him a little more. He's paying attention. He's paying attention to Dylan's cues. And that's a lot of what feeding is about, is really paying attention. Your child will tell you. And if you misread a cue, it's totally okay. But we're going to talk today about some cues that your child might be sending you that you may not even be realizing. Here's an alternative method. This is called side spoon feeding. So Dylan was using front spoon feeding. Jack's using side spoon feeding. I use this a lot in therapy. In side spoon feeding, you're placing the food on the teeth as opposed to the front of the tongue. When you put the food on the front of the tongue, as in front feeding, then the child has to, if it's anything more than like a puree, the child has to then move that food to the teeth and then chew it and then move it back to the center of the tongue and move it back. So if I want to bypass some of that, if someone's having trouble coordinating, then what I'll do is I'll use a spoon, put the food right here, pull the spoon out. It leaves the spoon where the teeth are. And then all they have to do is chew it, move it to the center of the tongue and swallow. So they don't have, you're cutting out a step. So here's Jack again. I think having a good hair day. So let me know what you think.
Okay, this is called side spoon feeding, and we do it to try to promote more chewing. You put it on the side. Whoops, that was not a great example.
Notice we're getting a lot more up and down movement here.
Of chewing and moving the food from side to side. That is what we want him to do. Let's go again. Off to the side.
And that's what I'm looking for right there, is that up and down,
Okay.
called a vertical
Just to
chew.
promote more advanced chewing. To the side. There you go. Good job.
So I'm sort of preparing Jack to move on to the next level of chewing, where he can handle the puree, but we want him to get to a soft solid. So I'm feeding him in that manner so that he'll start chewing. Speaking of chewing, let's talk about solid food. So think about, again, take a moment, think about your own child, think about where they are falling on this continuum. Then I want you to think about what skills they need in order to move to the next level. Again, feeding therapy is diagnostic along the way. So I have to see, what is this child doing now? What do I need to do to get them to the next level? There are 3 kinds of chewing that children develop. We as grown-ups all probably use a circular rotary chew. It's the way we normally eat, but as kids, we probably all went through these steps too. The first is a vertical chew, and that's what Jack was showing us. Big up and down movements of the jaw. It actually occurs when they're sucking a little bit from like a breast or a bottle. They're kind of using that up and down motion to squeeze. And then it also happens when you're chewing like lumpy solid foods. So all you can really do is break down like a soft food, like a banana or something like that. It's not going to be effective much beyond that. So if someone says to me, my child's able to eat, they're eating like a lot of purees, but they're really not transitioning to soft, solid foods, I'm thinking to myself, I bet they don't have a vertical chew. So the kind of chewing that your child is doing will inform the kinds of foods that you serve, right? So if your child can't chew a carrot, a cooked carrot, then I'm not going to serve that. I'm going to teach the skill before I serve that, because that child would be at a choking risk for that. So once you figure out where they are and you're serving them the right foods, then you have to think, how can I work up to the next level of chewing? Okay, so the second kind is a rotary chew. It's a little more mature. You can certainly eat a puree. You can also eat a soft solid. And we'll talk more about, I'll give you examples of all kinds of foods within these categories, but you can also chew what's called a crunchy dissolvable. So that would be something like a Mum Mum or a Cheerio or a cracker, because those are basically foods that turn into puree once they're in your mouth. Once you bite into a cracker and it mixes with your saliva and you kind of grind it up a little bit, you essentially have a puree in your mouth. So that's another reason why we often pair crunchy dissolvable foods with puree level in order to, because it becomes a puree in your mouth. And what you kind of do in a rotary chew is you're kind of moving the food side to side, but you're kind of doing it just like one side to the other. You don't have that like that circular mouth movement that you need in order to chew things like raw vegetables and meats. So for a circular chew, you're good to go. You can chew all textures, meat, raw vegetables. It's the most mature pattern. And you're moving that food from side to side using some nice jaw movement. So what kind of food should I serve my child? Well, if they're in the exploratory phase, so they're in the puree phase, but you're trying to get them to kind of do a little bit of chewing, you might serve them something called a hard munchable. And this is taken from Dr. Kay Toomey's SOS approach to feeding. She kind of formed this word or this phrase. Basically, it's a food that a child uses to explore but not eat. So this is very popular in like baby-led weaning sometimes, where you'll give a kid like a whole carrot that maybe is dipped in hummus, and they're kind of getting the hummus off, but they're not actually eating the food. Some parents feel that's okay. Sometimes in fact, later on, I'm going to teach you, you don't have to use a food to teach that skill. There's actually tools, which some parents might feel are safer. Parents have different views on that. But then the second kind of food is a hard meltable solid. So that's the exact thing I was just talking about with your Cheerio, your Mum Mums, your crackers. They're foods that basically melt when mixed with saliva and they become a puree. So then the hard part is getting kids sometimes to the soft solid. So that's your steamed carrot, a bite, or your steamed apple. It could be a cube of cheese or like a meatball bit or a chicken nugget. Your child has to have a bit of a vertical chew in order to get this food. So in order to chew this food. So you need to make sure that you're seeing that vertical chew, that really big up and down movement, at least before you introduce a texture like that. And then the mechanical solid, there's a spectrum of those, from soft solids like pancakes and muffins to hard solids like chicken breasts, raw carrots, fruit. And I would like to say here too, serving kids stick-shaped foods helps them a lot. I use this a lot in my therapy. We can easily place the stick where we want it on the teeth, as opposed to if I'm trying to get a little Cheerio in there, I'm probably going to put it in the wrong spot. But if I have a stick-shaped thing like a Mum Mum, for those of you who have little babies, you remember those, or if it's something like a veggie stick, I have control of where I place it. So I know it's going in the right spot. And also a child, especially I know like the children I've worked with who have PURA, they had a little trouble getting that pincer grasp that you need to pick up like a Cheerio or something, but they were able to pick up a bigger item of food. So cutting foods into sticks is great. You can even do it with like a peanut butter sandwich, cut it into sticks, or a cheese, instead of a cube, do a stick. Here I have developed for you a food continuum based on food texture. So starting with the baby Mum Mum to a veggie stick to a steamed vegetable to eggs. And as the child moves from like a crunchy dissolvable to a veggie stick to a soft solid like eggs, they're increasing their chewing patterns. So they're increasing in maturity in chewing. You'll also notice here that the colors are very similar. Sometimes if you have a really picky eater, they don't like a lot of variety of colors in one meal. And so here I just showed you how you can kind of keep things in a similar color pattern. Okay, this is another stop and think point. So we've talked a lot about, the kinds of foods, the textures of foods, all that stuff, how we eat. This is a part where you can kind of think about your own child again. What textures does my child prefer? So if your child is avoiding hard solids like meats and vegetables, maybe it's a texture thing. Maybe it's because they have some weakness in their jaw that needs to be addressed through exercises. Maybe they're chewing on the teeth, or maybe they're using a compensatory strategy. They're chewing it in the wrong place. And so they're limiting their foods by texture because they don't know how to chew the foods correctly. And so it either takes too long and they're getting tired, or they're having a hard swallow and that's scary, or they're choking. And then also where do they chew their food? So again, look for those big excursions of the jaw. You never really want to see food on the tongue. You want to see it on the teeth. You want to make sure they're chewing it with the power chewers, which are the teeth in the back, not these teeth in the front. Also, how does my child eat food? Are they biting straws, for example? Are all of your straws pinched down? If so, take a step back, try a different straw, try a hard straw. What preferences do they have? So do they limit by color? I just talked about, a lot of picky eaters will have limits of color. Usually they like round brown food, and that's not random. That's because most of those foods are highly processed foods that are easy to eat and they're predictable. So if you think about a Ritz cracker, it's always going to be the same shape, texture, size, temperature, color. All of those things are very predictable. So that's why those foods are typically accepted by even the pickiest of eaters. So let's go back to our soft solids here. So what does the child need to do in order for us to feel comfortable introducing soft solids? They have to be able to coordinate their lips, cheeks, and tongue for munching. So like a vertical chew, a munch. They can independently sit in the chair, and they also have the prerequisite oral motor skills. So in order to chew a soft solid, an oral motor skill they need to have is they can move the food to their teeth using their tongue. So remember that tongue lateralization we talked about. And they can close their lips to contain the food inside of their mouth. So you always want to consult a speech therapist before doing any of these or before making these determinations on your own, because, we feeding therapists are trained to really critically look at this stuff. And if your speech therapist doesn't have specific training in feeding, then you might want to, maybe hire someone else or look privately or, help fill in the gap. Because not all speech therapists have a wealth of training in feeding. We all have kind of a basic, but in order for some of these techniques, you probably need someone who has a little bit more training. All right, here's Dylan again. In this video, like I said, Dylan was having trouble transitioning to soft solids. So he's having difficulty. So we're using a chewy tube, which I'm sure a lot of you have heard of. Maybe some of you have not. We're using a chewy tube to teach him how to chew. Notice he has a vertical chew, so he's ready for those soft solids, but he was having a lot of trouble coordinating. So if a child is having difficulty transitioning, you can use these tools to teach them the skill before introducing that texture of food, since that food would be a choking risk at this point. So Dylan's munching on this chewy tube, and we've dipped it in a puree at this point so that he can learn to move his tongue to the side and move his jaw up and down while also tasting and swallowing food. So he is like an emerging eater of soft solids. And you'll notice in this video probably that he's a little uncoordinated at first, but he tries to and this is what I was mentioning earlier. He tries to put his tongue out. And what I don't want you to do is, as a parent, think, they're spitting it out. Kids will often resort back to how they tried to drink out of, or how they drank out of a bottle. And you drink out of a bottle by kind of pushing your tongue out, and then it goes in and you kind of get the milk. So a lot of kids will try to go back to that technique thinking, this is not working. Let me try what I used to do. And parents will say, they spit it out, they don't like it. So that's not necessarily true. They may just be trying a different technique that's not working. So here we go. Here's Dylan. So I'm putting the chewy tube on the side of his mouth, and I'm inserting it, if you notice, not from the front, but from the side. And I'm having that there's puree inside of the tube, and I'm helping him move his jaw up and down with my right hand to get him to sort of feel, oh, if I compress this tube with my teeth by moving my jaw, then a little bit of food comes out, and I like this food. And then I had to share this with you because Dylan learned to do his own therapy. Same activity, but after more practice, here's Dylan doing it on his own. Notice again, vertical chew, big mouth openings, but his tongue is on the side. He's moving his tongue over. So he's learning this skill by using this tool. At this point, I would feel comfortable introducing like a banana spear to him because I think he can handle it. I think he can do it, but I feel comfortable because I've used a tool in order to teach it. Okay, so now we're up to the last texture of food, which are hard solids. These are like your bagels and cream cheese or your burgers or maybe a string cheese or a cucumber. The child needs to be able to safely chew and swallow those crunchy dissolvable foods. They also have to be able to chew and swallow the soft solids, and that can be in cube form or in stick form. They also have to have, and this is super important, the prerequisite oral motor skills. So they can move the food with their tongue to the teeth. They can close their lips around a spoon or a piece of food to hold it in their mouth. And they can use the tongue to move the food back for a safe swallow. Here's Jack using a hard munchable. That's that term that Dr. Toomey coined, but it's using one food to transport another food in. So in lieu of using a chewy tube, Jack is using a pretzel rod. This is practice for transitioning for him to hard solids. He can fairly easily hold this food because of the shape. Also, it's safer because I can pretty easily remove that food if a problem occurs. And we're really also working here on Jack finding his mouth. So if we're working kind of like self-feeding and spoon skills, this is a prerequisite that he's going to need to have. Being able to kind of negotiate where to put it and how far in. So this is Jack eating a pretzel rod dipped in peanut butter.
Watch it dip and back. Oh, we gotta hold it. Good job. Find that mouth. Good job. Good job.
Not really sure yet, but
with a little honey bear.
we get there.
Friend. Oh, that's good chewing for a second. I hear it.
And there, he figured it out. So you can kind of see the same movement that Dylan had. He's learning, finding his mouth.
There we go.
Good day for pretzel with peanut butter.
There you go. And this is Jack eating a cubed solid. So now we're moving into harder to chew foods. This is a beet. Jack loved like pickled things, highly flavored foods. So this was a beet and feta salad for this little guy. Fancy. You'll notice that he's using more mouth opening and closing here. He's learned how to munch chew or vertical chew, and he has an emerging rotary chew here. I don't expect for you guys to sort of see that, but it's cool if you do. I like to use at this level a short metal fork with a thick handle. Again, easy for the child to hold, but the metal is a good predictor of temperature. So I like to use that, especially with like kids like Jack, where they need to sort of learn about that kind of thing. So here's Jack moving into the next level.
Rolling.
So I'm using that same technique, side spoon feeding, but it's side fork feeding. And he's controlling the food by keeping his lips closed. He's gaining more control. I'm seeing a little more of that rotary chew as opposed to a big opening and closing. We know that Jack is ready.
Okay, we're gonna put it on the other side.
I wanted to remind you guys here,
Very
don't
good.
feed on one side because you'll have an asymmetrical child. Those cheeks are muscles, so you want to build up both of the cheeks on both sides. And then of course you have to see Jack today. This is a feeding session that I had with Jack last week. We're working on self-feeding using forks.
Hi. Okay, which one? Which one? This one. Yay. Good job. Now down. More? Not yet, Rachel. I'm still chewing.
Notice
More.
the chair and the position of his feet. He's still supported.
Look. More. Aha.
Okay.
Good job. And down. Yay, Jack.
So that's how I taught Jack to eat from a fork. You can see there's many, many steps here. It's, you know, try not to get discouraged. It's not easy, but, you know, you just have to really task analyze every part of it. You might want to take a quick pic of this slide. A lot of parents will ask me, how much should my child be eating at any one age and how much of each food? This is a really great rule of thumb. I took this from a book called A Sensory Motor Approach to Feeding by Lori Overland, who is an amazing feeding therapist, and I learned a lot from her. So this gives you kind of an idea of how many calories and where they should come from. And then the last thing, and there's no way I can devote enough time to this, is the sensory component. So if you think about your main senses, smell, hearing, taste, sight, touch, then we have things like body awareness, movement awareness, things like that. Sensory system is critical to eating. So we really need to kind of talk about them because they play a major role. Think for a moment about your body response if someone were to serve you a brand new food. And I, you know, grew up in Virginia. We didn't have a lot of seafood, and we certainly didn't have a lot of like gelatinous seafood. But I know that's something that, you know, in different parts of the world, people are eating. So that's kind of where I always think, like, what would be something that'd be very foreign to me? So first, I'd probably look at it. I'd probably try to figure out what texture it is. I might poke it with a fork to see how it feels. That'll give me a little information about what it's going to feel like in my mouth. I'll probably smell it to try to figure out what it smells like. And if it smells like something I might have had before, if all of that feels okay, I may poke it with my finger, again, getting a little more information because now I've touched it. Maybe I'll take a very small bite at first to sort of see what it's going to be like, or I'll lick it before I bite it. You're not going to put a huge piece of this new food in your mouth, right? Sometimes I might dip it in something I'm familiar with, like ketchup, to mask some of the smell or the taste. So that's how we as just grown-ups or people engage with a new food. And your child is doing the same thing. But the difference is we have many experiences with food under our belt in order to compare what this new food is to an old food that we, you know, I know maybe I've had fish before, but just never in this form, or, you know, anything like that. So your child really has not a lot of those memories or comparison points. So each food really feels like a new food to them. I say this to say, when your child, you serve something and they won't eat it, keep exposing them to it. Every time you expose your child to a food, their sensory system is kicking in. So they may think, oh, I smelled this food before. This smells like the chicken that mom and dad had last night, or I've tasted something like this before. So keep exposing your child without the expectation that they eat it, because you want them to have a sensory awareness of what this food is going to be like. Okay, so now think about your own child again. We all have a sensory system, and all of our sensory systems are a little different. You might have a hyposensitive child. That means their sensory system is under responsive to sensation. So if that's the case, you want to increase increase the sensation of foods. So for hypo kids, you might want to have really cold water or water with lemon in it, pickled beets and vegetables, ketchup and barbecue sauce for dips. You're increasing the sensory component so that it feels normal to them. For hypersensitive kids, you want to do the opposite. These are kids who have an over-responsive sensory system. So those kids would never touch a pickled vegetable. They're going to like a bland food, a room temperature water. They're not going to like mixed textured foods like a rice pudding or a tapioca pudding, or like yogurt with fruit in it, chia seeds. These are things to stay away from. For your hypersensitive kid, most of us have a mixed sensory system. So they may be under responsive, let's say, to taste. So you need to increase the amount of taste, salt, sweet, whatever, but they may be over responsive to sight. So you may want to limit the amount of that food that's on the plate, because if they get a whole big plate full of food piled up, they're going to say, I'm overwhelmed, I can't do this. At this point, it gets a little more complicated, and I do think you need to see a trained professional. Occupational therapists are wonderful at diagnosing sensory systems and sensory issues. I work almost always with an occupational therapist when I'm doing feeding therapy. And then ways to prevent a picky eater. The first one is very simple: eat together as much as possible. That when you do that, your child is smelling, hearing, seeing foods, all those sensory experiences are coming. You're building that social connection. You're building, happy memories. Even if it's not so happy at that particular meal, you're still building memories. Be patient, offer new foods many times without the expectation to eat it. Oftentimes in my feeding therapy with like older and pickier eaters, I'm just eating in front of them. And then at some point they're like, I think I'd like to try that thing that you keep talking about. I'll also compare it to other foods that I know are in their diet. So if they eat, like I have one child who only eats potato chips, and we're working into a French fry, which may not sound like the healthiest of transitions, but it's important for him. And so I was saying it's made from the same thing. It's salty like a, potato chip, but this is soft and that's crunchy. So making comparisons helps provide that with kids. And don't stress as much as possible. They can feel it, especially young kids. They feel your stress. If you can, let kids help prepare the food. There's always a way to have your kid tear lettuce or sprinkle cheese or something. Kids are more likely to try a food that they helped make because they know what's in it. Don't serve too much at one time. I love these little section plates. They're by Fred. That's the name of the company. And they, the child, if they're overwhelmed by the amount of food, you put one bit of food in each component. And then really key is allowing your child to feed themselves when they can, because then they're making the choice of what goes in their body, and that's really critically important. Finally, here are some of my favorite resources, and I used a lot of these in my talk today. If your therapist doesn't know as much as you would like for them to know when it comes to feeding therapy, you can read these books and maybe offer some suggestions or say, hey, I had this idea. There's this thing called food chaining, and maybe we could try that. Or there's this approach to feeding, the sensory motor approach to feeding, which includes a lot of the tools that I use in my therapy. So this might be a way to kind of bridge that gap. Diane Barr wrote a wonderful book called No One Ever Told Me or My Mother That, and it has so much information. If you have a note of any upcoming new moms, I'd highly recommend it as a book for them. It just has everything you would need. Melanie Potok is also someone you could follow on Instagram. She wrote this great book called Adventures in Veggieland. It's how to kind of play with food. And then Raising a Happy and Healthy Eater by Namali Fernando. And checking out just the SOS approach to feeding. They have a website that you can kind of see more about what that approach is like. That's for more of your pickier eaters versus your motor difficulty eaters, and the motor kids, the muscular component is what I was showing you a lot today. My favorite tools, these are my 3 favorite tools for drinking. The recessed lid cup by Talk Tools is the purple one in the middle. They have a, I do not like the 360 cups that parents are using a lot these days. You actually have to bite it, and it teaches the complete wrong way to drink from a cup. It's just convenient because you can take it and throw it in your purse and it's not going to spill. But this recessed lid cup has 2 little holes in a lid, and it teaches the child the proper way to drink. So I'd recommend something like that. And then my favorite feeding tools are these. We can talk more about them. Feel free to take a picture. I also am gonna, the PURA Foundation people who coordinated this are going to upload a copy of my talk onto the website, I believe, so you can have all this information as well. If you need to get in touch with me, here is how you do it. Feel free to take a picture of this slide. And I believe my contact information is also on the website as well. So that concludes the first part of our talk today. I'm going to stop sharing my screen and turn it over to you, Caroline.
Thank you very much. Thank you so much, Rachel. I've learned so much. And I just wanted to add just a very personal thing. I can't imagine Jack having a bad hair day. He looked gorgeous in all the videos. And it was—
He really doesn't ever have a bad hair day.
And it was so lovely to see as well, the last video, how much he's managed and succeeded. It was quite emotional, very nice.
Good, yeah.
So we're going to start with some online questions that were submitted before. And the first one is, what is your opinion about VitalStim, neuromuscular electrical stimulation?
So, to be frank, I'm not that well versed in it or how it's used. I know that I have had children who have used it. What I found is I see kind of like a quick improvement, but it doesn't really last long. It's not necessarily like a long-lasting solution. I think really you have to think about building up muscles and then building up coordination of muscles. And so we all want kind of like a quick fix, or we want to explore something that's like an impossible, like maybe that's going to be the key. But I don't know that I've seen enough of a improvement in the limited exposure that I've had to it that I would necessarily recommend it.
Okay.
I'm sort of like of the like tried and true, like good old fashioned hard work, wins at the end of the day.
Well, thank you. The next question, do you see a difference in treating swallowing, feeding problems if the disability is genetic as opposed to brain trauma?
So in the end, I would say no. It depends on, where the trauma to the brain occurred. I can say that like if it's a syndrome and we sort of know the patterns that occur amongst children who have this syndrome, then you kind of have a better prediction of what you're going to be looking at and what you're going to be treating. I sort of, versus a brain trauma where, it kind of depends on where the trauma occurred and what it's affecting. I guess in that sense, if it's like neurological or a nerve issue, then you would have to kind of do a workaround. So you'd have to find another part of the brain that could maybe take over and control that. Similar to a speech issue called apraxia, where the brain tries to send a signal to the muscle, but it misfires. And so the speech sounds like kind of gobbledygook. So what we do is we teach a different part of the brain how to make speech and make sounds, and we are able to use that part of the brain to do it. So, I treat every child as I just sort of look at the child and I say, again, task analyze, what can they not do? And how can I get them to do that thing I want them to do? So if they're not drinking out of a cup, how do I break those steps down into the smallest amount or the biggest amount that they can handle and then work my way back up? So it doesn't really matter what the etiology is as it does what they're not doing that we need them to do. And I always consult with the doctors. I always have a doctor clear a child for a texture of food or a liquid or something like that. Jack had a lot of swallow studies that I was part of. So we would, look at how he's swallowing and see if there's like silent aspiration. So we thickened things until he was ready for that. So, I think too, like collaborating in that respect is key. I mean, we're talking about kids who have a lot going on. And while my focus is feeding, there's this child here who's trying to do a bunch of thousands of things in a day. And so I want to kind of know those points along the way so that I'm comfortable medically doing what I'm doing, but also functionally, I know here's what I need to do to get to that end goal.
Okay, perfect. Thank you. Is it common for children with PURA syndrome to go on feeding tubes?
Unfortunately, it is common. Yeah. And, I think having really good therapy in the beginning is really the key component. So Jack was actually, we never got to that place, but it was definitely in the talks that, if he's not able to get more liquid into his diet, then that might be a route we're going to have to go on. And as I said in my talk, for so many reasons, it's so important to keep kids off of a G tube. There's the chewing component, just the whole thing, right? It's all everything, muscular, social, all of that, sensory. That said, I work with a lot of kids who I'm transitioning off of a G tube, and they can still get those experiences, later in life. There, it really has to do with where you fall on the height and weight charts. So like, for example, Jack was pretty dangerously low. And so I think that's kind of like when I got called in a little bit just to like see how much can we get into this kid right away. And that's another part of feeding therapy is you want to make sure that adequate nutrition is at the forefront of your thought. So if your child is only eating puree and you can't get him to a soft solid yet, then start to think, how can I increase the amount of puree that I can get them to eat, but also the fat and protein and all of that in the puree. That's why I put those charts up. Are they missing the calcium? Are they missing the protein? Are they missing vitamins and minerals? Do they need more fat? I typically consult with a pediatric nutritionist on this. And we did in Jack's case as well, where we said, okay, we know Jack can now eat a puree. What can we do to make this a really meaningful, puree for him? He only has about 30 minutes and then he fatigues. So how can we increase the calories? We added chia seeds, we added hemp hearts, we added like the most delicious, decadent yogurts, from around the world, like just these, we would die to have these, in our mouths. So think about getting that child. To me, that's the main thing, right? Getting adequate nutrition and getting as much of that in as we can. While then I'm working on that chewy tube or that honey bear, behind the scenes or under that. But the main thing is like meals are for getting in calories and getting those calories in any way you can, because you really want to try to keep your child off of the tube.
Thank you very much. Well, we'll continue with Coffee with Rachel with the Q&A box. There's quite a lot of questions.
Okay.
So let's go to the first one. Hello, thank you for the presentation. I have a question because my son is unable to drink water, so we help him with syrup in the water. What can I help him to drink? Only water and nothing with sugar?
Well, if he has a dairy tolerance, if he's okay with dairy, then I would work on like milk or a thickened milk. I often have kids, if he can drink from a straw, drink smoothies. So, crushing up a bunch of fruit and vegetables, thickening it with, yogurt or a banana. That's a good way to get like a liquid in that you're, again, you're increasing the calories of, with no sugar. Yeah, I mean, that's the main things that I would think of. You can do a thickened, like a thickened broth. So, the other thing you can do is if it's a problem of choking, that it's going down fast and that's why you're thickening the liquid. The other thing I recommend, again, think about slowing transit time, is using a smaller straw. So a harder to pull from straw. I've even used those like little cocktail straws, almost like the coffee stir, if the child really is having a hard time. Because you really have to pull harder, and it's, again, it slows the transit time for it to go down the mouth. But I would go with like a smoothie or a milk product, even like those drinkable yogurts. I don't love that they're in this weird tube, but you could put that drinkable yogurt in like the same thing that he drinks his water out of, and then you're getting a little more calorie, but kind of mimicking that viscosity of the liquid.
Okay, thank you. The next question. Many children with PURA syndrome have a high palate. For my daughter, food often gets stuck on the roof of her mouth, which then impacts her chewing. Do you have any tips for preventing food from getting stuck in the high palate?
Yes, that side spoon feeding technique is really critical here. No food should go in the front of the mouth, because immediately what happens is that food goes right up into the palate. And then you have this buildup of food, and sometimes it'll go down. Choking can happen. So I would limit the amount of food that she puts in her mouth at any one time. And then I would also always place it on the side, in sort of in the back. So the side spoon feeding technique, where we kind of place it on the teeth and we pulled the spoon out, that's how I would feed her, or have her feed herself. And then secondly, I would have her do like a wash with like a straw and some water in between a few bites, to try to clear out some of that food that's going to be stuck on the palate. But so limiting the amount that you have in the mouth at any one time, placement is key. And then also clearing it with some liquid, if she's cleared for regular liquid.
Do you have any advice for caregivers on finding a speech therapist who has specific training in feeding therapy?
Well, there are Facebook groups, that are feeding therapist groups. If you're looking for a therapist who's trained in kind of the techniques that I am, I believe Talk Tools themselves, they have a provider list, and they're an international company, so they probably have providers, or they do have providers all over the world. If you're seeking a private therapist, I would definitely look for one that has listed specific trainings. And instead of typing in speech therapist in your area, type in keywords like feeding therapist. A lot of therapists are afraid of feeding therapy because of the choking risk, and because, like I said, we get some training in graduate school, but to really feel comfortable, I had to take a lot of courses to know really the ins and outs of it. So I would really kind of ask a new therapist, like what courses have you taken? What trainings have you taken? What techniques do you use? What types of therapeutic, do you use tools? What kind of methodologies do you use? Like I said, some parents really like the using food to teach about other foods. Some parents and some therapists really like using tools, so it's like kind of a safe transit. But I would go on the Talk Tools website if your child has more of a motor-based speech feeding issue, which would be kind of like what we talked about a lot of kids with PURA do. If you have an older child who's exhibiting picky eating signs, they don't have to be older, but older than like a baby, then I would probably go to the SOS Feeding Tech Approach website, and they also have a list of providers there.
The next one starts with a very nice comment. First of all, it seems impossible for Jack to have a bad hair day.
This is the common thread. Okay.
My question is about biting. My son used to hold his food in his hand, bite into it and eat. Now it seems like he forgot how to take a bite. He is just waiting for us to put the bite-sized food into his mouth.
Okay, I'm wondering what changed and when, and if there was an incident. or if there has been anything physiologically or physically that's changed. To me, if that's, so he's waiting for a parent to feed him as opposed to feeding himself. So to me, usually that means that he perceived something as difficult, and he is trying to sort of take the easier road, or something was scary, and so he's kind of a little gun shy to feed himself again. What I would do is I would think through what would be the easiest shape for him to hold and self-feed, and then I would make it into like a game, like mom takes a bite and then you take a bite, or the stuffed animal takes a bite and you take a bite. Making it silly is often, a lot of my feeding therapy is silly. So, we're taking a dinosaur bite versus a mouse bite, or we're taking a big boy bite versus a baby bite. And, so we're doing different things like that to make it fun. But I would play like games that would encourage him to take some of that on himself. But I would also think through, when did that happen? Why did it happen? And what could I do to kind of show him that it's safe and that he can feed himself again? Yeah, that's kind of how I would answer that.
The next question is related to that one. It says, my daughter is 3.5 years old and has really come on with her feeding. She has managed solids for the last year or so and does well with drinking from a straw. She has started to be able to feed herself finger food, but recently has been really reluctant to take bites, waits for me to put bite-sized pieces in her mouth, and doesn't even want to close her mouth around a fork. She's not so bad with a spoon.
I mean, so sort of same advice here. I would really think back to like what at the heyday of it. What was she eating? What was exciting about it? How can I replicate that, today? I would think doing some like family meals together, where you're not, the mom isn't necessarily sitting in front of her child and feeding, directly, because then the expectation is you'll feed me, but maybe sitting next to the child, as you would in like a, any dinner restaurant or anything like that, so that the child kind of has the opportunity to self-feed, but mom's there to help, or dad or whoever is there to help, kind of pick up the pieces a little bit. But think about positioning yourself away from that I'm feeding you, you're eating what I'm giving you kind of thing, and try to give that child a little more autonomy. You might find in the beginning that they are resistant to it. Most kids are resistant to a change if it's harder, right? But, at some point, she may take that piece on her own and feed it to herself. And that's kind of, again, that's what happens a lot of times, is they realize, oh, okay, the expectation is for me to feed myself, and I'm going to have to do that. Mom, as a parent, we want to be so attentive to our kids and cater to their every need, but sometimes the need actually is the longer term goal. And that's really hard for parents, I know. So it's so much easier for me to give her that bite of food now, but if I don't give her that bite and I wait a little bit, and then she ends up realizing, oh, I used to do this, I can feed myself again, then you're giving her, the ability to feed herself forever, which is really the ultimate goal. It's like that expression, like give a man a fish or teach a man, to fish. It's like that. Like you think about your child in that way, that yes, you want to get the nutrition in. Yes, it's nerve-wracking, all of that. But sometimes if you back away a little bit, and even just positioning yourself next to them instead of in front of them, I think that helps like kind of sever that line of like, mom's here, she's going to do it for me, upping the ante, upping the bar, raising the expectation.
Definitely. Now the next one, this is not necessarily a question, but I really like the information on sensory components of food. My daughter absolutely loves crunchy foods. If she's not eating other foods and I put a few crunchy foods, cereal, crackers, etc. on a plate, she will usually begin to eat some of the other foods as well. This might be helpful for another family as information, but I'm also curious if that is typical.
I use that all the time in therapy. And I certainly tell parents that all the time. if you're eating a food that you're not sure about, and there's another food, kind of a safe food right next to it, then I'm more willing to be a little adventurous and take a bite, knowing that I can immediately put something in my mouth that I know the taste, I know the texture, I know the flavor, it's like that dipping it into ketchup, right? Like you're making it a little more familiar. So those sectioned plates are great for that kind of thing too, where you put a whatever they're not that interested in, and then they get a crunchy bite, and then another one, and then a crunchy bite. Eventually it's like 2 bites and then a crunchy bite, 3 bites. But yeah, having a familiar food or a preferred food is a great way to expand what they can eat. I think that's a great suggestion from that parent. And it's also, I definitely support that in feeding, and also in when you're eating as a family. I often suggest that you as a parent have foods that we're trying this food out, like we're working on, let's say, chicken, and everyone's having chicken and we're trying the chicken, but also the child has some available foods that are familiar foods, because you want to reduce the anxiety around eating. So if there's something familiar, you're more likely to eat something that's unfamiliar. One thing that happens is if kids get really nervous about eating, so like if there was an incident, their body goes into fight or flight mode. And when you go into fight or flight mode, the brain actually sends a signal to your stomach that says, turn off hunger. We are in a critical, scary moment here. And so bringing that anxiety down is a very good way. It's necessary in order for a child to continue to eat, because your body is saying, whatever you do, don't eat right now. So certainly mixing in, even with family meals, like in America, Thanksgiving is huge meal. And I often tell parents at that time, feed your child a preferred food first, and have the whatever it is on the table, so like, they feel, or on their plates, they feel good about it, but also have that crunchy thing. The other thing, I could talk about this question for an hour. The other thing is they might need that crunchy thing to regulate their sensory system. So if your child, so crunchy things wake us up. Soft foods kind of put us down a little bit. So if your child they might actually need that crunchy food within their meal in order to keep their arousal, in order to keep that sensory system at the just right place for them to be eating foods with you. We as adults do the same thing. Like, some people, I love like casseroles and things where everything is kind of in one, and that's fine. It's, whatever. But my husband, he needs a crunchy thing and a soft thing and a, hard thing. So he needs that for his sensory system. Like that's what he prefers. So think about your child in that way too. What is their sensory system requiring out of that meal? And think about serving foods that are going to help them regulate the sensory system.
This question it's 2 parts. It's from the same person. Do you ever work with older folks? My daughter used to eat normal food, but after a long illness where she had to start using a feeding tube, she's on purees now, but would love to get her to eat more sorts of foods. And included, what do you think of thickening powder? We are told to use it for all liquids.
So part one, yeah, I mean, it's kind of the same techniques, right? We would task analyze where she is. If she was on a feeding tube, then there could be muscle atrophy. So she may not be able to she may not be able to eat those foods without working on, I literally do exercise programs for the muscles of the face, right? Like, just like you would go hire a trainer to make you muscular in your body, you can hire a feeding therapist to help make you muscular in your face. So if she had atrophy, which means the muscles kind of shrunk and, they're not performing the way they were, then implementing an oral motor exercise program would probably be something that would be helpful. You would have to task analyze what is it that is preventing her from moving on to the next stage. And then probably at that point, I'd probably use tools to build up the muscles. So thickening liquids, I always refer to the doctor. The doctor, is the medical professional. I really try hard in my practice to stay away from artificial things. So I might try to think of things that are already a little thicker. So if it's like a nectar thick, now I'm not whatever your doctor has said you should do. Okay. If I have someone who's cleared for like a nectar thick liquid, then I might literally say there's mango nectar at the, store down the road. Let's get that. Let's put that in a straw. Let's see how quickly that is going down and can they control it? And then we'll work on different sizes of straws to figure out which straw is going to slow the rate of oral transit enough that they can safely swallow that. Now, if it's a really medical complex case, I would do that during a swallow study. So in a swallow study, you can literally go through all the thicknesses of liquid and see if there's like silent aspiration, meaning it's going down the wrong pipe, but they're not coughing it up, because that can lead to respiratory infections, bronchitis, pneumonia. So you really have to be careful. Sometimes you just have to use a powder thickener is the answer. If that's what is available to you, if that's what the doctor is saying. Now, that said, I might go to that doctor and say, I understand. I might write a letter to the doctor as the feeding therapist, or you as the parent could say, I understand what you recommended. Could I use naturally thicker liquids? So again, like a smoothie, a shake, a nectar, a mango or a peach or a guava nectar, a drinkable yogurt, things like that are all of the same thickness, but you're not using anything artificial into your child's diet. And that's my personal philosophy, but I also go with whatever the family's preferences are.
Okay, great. There's two from the same person, so I'm going to join them. What can I give my child to gain weight? He's so long and he hasn't gained weight for 6 months, but he eats very well. And is there a technique to prevent my child from grinding his teeth when he eats pieces of food?
Yeah, okay. The easier answer is the first one. So yeah, things like chia seeds, hemp hearts, any additives that you can, so let's say he's eating like pudding, you can add chia seeds, hemp hearts, other fillers like that, that are really going to provide more protein and more fiber. I would definitely, if he's having trouble gaining weight, then I would go the same kind of route we did with Jack, where he's eating, ultra thick, rich yogurts, full fat, when we made like a pasta or something for Jack, we would use like butter and, all this stuff. Now, this has to be for a child who can expel those calories too. So if your child is not mobile, then you want to think about going more of like the chia seed, hemp heart, route. If they're, it's calories in and out. So if they're moving and that kind of thing, then you can kind of go with a little more of like the high fat stuff. I'd probably talk to a nutritionist and say, my child is not gaining weight, but they're eating well. And a pediatric nutritionist could also, give you some advice on how to add things into the diet that are healthy, but also, more that are healthy. And then, I hate to keep going back to the same answer, but I like smoothies I use with kids all the time. Number one, you can add almost anything to it. They're not going to know. If it was like that kid, I'd probably add like peanut butter and, full fat yogurt and like bananas and like really, if whatever he's going to eat, you want to make it count. So you want to have like a nice, well-rounded meal, but, I would add almond butter, different butters, things like that. Always, thinking about like dietary restrictions. The tooth grinding thing I have found prevalent in kids with PURA. So I think that's something that's going on. I don't know, did Joshie ever grind his teeth when he was eating?
He does still a lot.
So it's a good question. And what I try to do is, so what I think is that the child doesn't know how to adequately move his jaw up and down to chew the food. Grinding is something that we do with food. So if I have a cracker, I'm kind of grinding it in my mouth, right? Anyway, but if I don't know how to regulate how much I open and close my mouth, and I'm really keeping my jaw closed, then I'm going to hear that. It's an awful sound. I know it. I'm going to hear that like grinding sound. So if that's the case, I might add something to the food. So think about what food does your child grind on, and then I would either try to add something thicker to that food, or I would try to do a little, well, you can do, there's like a massage kind of thing, a release of the jaw that you can kind of do where you press on the back. That can be helpful. I don't know that I have a great answer for this question, but it's something that I'm definitely exploring through my practice. I think you and I did talk about that a while ago, about the grinding, and Jack used to grind his teeth too. I'm seeing some other parents are, you know, that's a good area for me to think about and explore. So I'll get back to you on that.
Thank you. And then we have Jean, who's just written, fabulous presentation, Rachel. Jack has made such great progress thanks to you. So lovely.
I hope I supported her wishes there.
And then we have another one. How do you get a child to take food off utensils with lips rather than their teeth?
Oh, so that is also, okay. There's a technique called upside down fork feeding. I have 1,000 feeding utensils here and not one fork, but okay. Let's say this is a fork. Oh no, here's a fork, okay. So instead of feeding them the food the regular way on the fork, you turn the fork over and you present it to the side, okay, right to the lip, and then you pull it out that way. So you're saying like to go like that, I'm assuming. So one thing you could do is you could just the jaw hold that you saw me do with Jack 1,000 times, you put your finger and thumb under the jaw, and then as they go to take it, you close it right where the lips are. So you're kind of forcing them or showing them what to do. Also keeping it really small, the bit of food very small, will also help with them use their lips. So upside down onto the side like that. We also use that if you're teaching a child to break off food. So if you put like a veggie stick in and you pull down, then naturally the lip will kind of follow with you. There are also a series of exercises that you can do for the lips, using things like a toothette, which is like a little spongy tool where you kind of go in and you activate the lips. So that tapping thing that I did with Jack, I was trying to wake up his lips, activate the muscle. So there's other like exercises you can do, which you would need to have a feeding therapist show you, because there's a lot of, you have to do it in a very specific way, that you can kind of work on opening the lip, activating the muscle. There's stretches you can do that will help with that. So it's about placement always, size of the food. In this case, I would make it small. And then I probably would start to implement like an oral motor program for that child, so they're more aware of their lips. I would also look structurally. Do they have a lip tie? Is there something, why aren't they getting it off the spoon or the fork with their lips? So is there something structural preventing them from doing it? Is there something functional? And if all those things are in check, then I would try to use a different technique that would activate the lip more.
We just have a last one, which is a follow-up from, she's the one who asked before about her son who forgot how to take a bite. She just wanted to share that it was when he started school and they started to send the lunch so that it was easier for the school and it was in small pieces. So that is what happens. And she said, thank you very, very much for your answer.
Yeah, right. So let's go back to where that was, right? And let's work back up from there. That's another thing to remember too, is that there's going to be things that happen in life. Kids get sick And, even a cold can set you back. The little girl that's on the G tube, we have to kind of think about, okay, we got to work all the way back. And that's what therapy is. It's like kind of this ebb and flow. And when you're in the part where things are going back, it seems impossible or like it's just not going to happen. But, you just kind of keep at it, right? Like keep finding the answer, keep finding, what technique is going to work. Again, as parents, you don't have like the training to analyze muscles and all this stuff, but you can probably figure out what your child is doing or not doing. And then you can at least try to tell that to the professionals. And the other thing I would say, I get this from parents all the time, is they're like, I was telling my doctor this for 3 years and he said it's normal or it's fine, but I knew as a parent that it wasn't. And then, so they didn't, they were like fighting for it, but they weren't like the advocate they wanted to be. So my other advice is to say, if you feel like, your child is having an issue, keep at it, like keep finding, somebody who can explain it at least. And, you probably as a parent have to do a little bit of digging. That's why I suggested those resources to try to help you kind of have those aha moments where you're like, that's my child and this is what needs to happen. Right.
Yeah.
Yeah.
Thank you so much, Rachel. Thank you so
You're
much for everything. It's been amazing. As always, your presentations are wonderful. You're wonderful. Just thank you so much for your time. There's no words to express our gratitude, really. And I just wanted to remind everyone that they can still ask some questions after online for Rachel, and she can answer after the conference. And Rachel Rose has been our last session for today. And tomorrow morning at 9:30 ET, we will be starting with Angel's Bonser for self-care for caregivers. So we'll be looking forward to seeing you all then. Thank you very much, everyone, for joining. And thank you, Rachel, for all your amazing information, knowledge, time, and for everything.
Thank you so much. Thanks, everybody. It was a pleasure.